Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with John. How are you doing tonight?
Hey, Dennis. John here. I'm doing great. Thanks for having me on.
Hey, perfect. And so the reason why I asked you on is, if I understand this right, you are reworking the JTS's trauma, chest trauma kind of algorithm, CPG. And so I wanted to take this chance to kind of pick your brain about chest management. Before we get into it, would you mind doing just a real quick introduction of yourself?
Yeah, sure. My name's John. I was a Ranger medic in 3rd Ranger Battalion for about 12 years. I went to IPAP, DoD, Inter-Service Physician Assistant Program. And then I spent some time in 3rd CAP, 3rd ID as a flight surgeon. Then I went to the 1st Ranger Battalion as a PA for a few years. And then I went to Med COE and taught at the 68 Whiskey AIT Schoolhouse. And now I work in a military-civilian partnership at Cooper University Hospital for trauma service.
Perfect. Full circle there. So jumping in, chest trauma, obviously very serious. And with the seriousness, you get a bunch of kind of like anecdotes, do this, don't do that type of thing. So there's some, I wouldn't say confusion, but there's definitely some hiccups along the way, translating, good hospital medicine to down in a ditch. So just kind of starting off super basic, chest seals. When I went through the course, it was chest seal, essentially everything from their face to their knees, with as many chest seals as you can, because that's what's best for the patient. It seems like we've started moving away. How far wrong are these young whippersnappers?
Well, I think there is kind of a trend to overuse the chest seal. And I never want to tell a guy, on the ground exactly how to do something, because, I'm not there. But, in general, I think we do overuse the chest seal, kind of like what you're talking about. There's an injury from like the crike to the umbilicus, put a chest seal on it. But I think one of the things that, we often leave out is that chest seals, if they're non-vented, can actually cause a tension pneumothorax. So they're not completely benign. And that's why kind of in COTC and some other organizations like Thor and these different kind of committees, they're very, chest seals just aren't this kind of thing you just throw on. It's specifically for a sucking chest wound or kind of an open pneumothorax, which is basically you have an injury in the chest that allows, your pleural space or your lung space to communicate with the atmosphere. So if your wound isn't doing that, technically you shouldn't, or reasonably you shouldn't apply a chest seal, because essentially it can cause a tension. It can convert an open pneumothorax into a tension.
Yep, I understand. Absolutely.
Yeah.
Now, in practicality, I open up the guy, take his plates off, I open up his shirt, and I see a bloody mess. How do I know if this is communicating or not? Because it's bleeding, right? So that's not good.
Yeah. Yeah. I mean, that is really difficult. I think. And I think that's why, like, a lot of times you're just put a chest seal on. But if you do have time, and let's say you rip his plates off, you cut his shirt off or whatever. If you can even just swipe the blood away with your hand, just physically, if you can use like a red light or green light, some low light. You can even physically look at the wound and see, is it penetrating enough to even enter the chest? Are there bubbles coming out of it? Does it actively, suck and blow, kind of like what we do in trauma lanes and different things like that? Then probably, it'd be, indicated to do it. And if not, and if you don't know, then put a chest seal on. But I think the key takeaway with chest seals is that they can be harmful, and that, if your patient does go in a different direction, you can't figure out why, multiple things start happening. Just remember that chest seal's on there, you put it there, and it could be a cause of decompensation.
Maybe it's
pneumothorax.
Yeah. Now, maybe this is a dumb question, but everything is a pendulum swing back and forth. Chest seal everything. Now, be smart about it, and chest seal only certain wounds. What if it goes to the extreme and we're like, no more chest seals on anything? How far wrong are we going to go?
So I think that's a tough question. I think there is a place for chest seals. I think the indication to use it is a lot rarer or less likely than we think. And really, what you could do is basically, like, the way I would look at it is the patient spontaneously breathing? So are they breathing on their own, or are they requiring positive pressure ventilation, whatever that is, with a ventilator or a BVM? If they're spontaneously breathing and you don't apply a chest seal to them, probably nothing immediately bad is going to happen. And the reason you'll know that is because your body's going to compensate for that chest trauma. You'll increase your respiratory rate, you're going to increase your tidal volume, the opposite lung, or the opposite thorax, hemothorax, that isn't injured, is going to increase negative pressure. So your body's going to compensate during this injury. So initially, I don't think anything bad will happen. I mean, you'll eventually have to cover that chest wound if it communicates with the outside. But that's time, and I think, as a medic, you could probably understand some of that physiology, and you could either wait to apply it, you could apply it immediately and potentially have to remove it, or just do nothing and then, go through your march pause sequence.
Mm-hmm.
And, you could always go back to it as well. Just because you don't apply chest seal doesn't mean you're going to kill the guy right away. Kind of like how we train,
right?
How we kind of train these trauma lanes where it's like, oh, you didn't, it's like a 10-minute lane, and you didn't apply chest seal, you killed them. I mean,
right. That's not real.
It's not going to work that way. Yeah.
Oh, what the hell?
Yeah, because your body's going to compensate. So that's for if you're just breathing spontaneously or not, if you're not ventilated. But if you are ventilated and you've applied a chest seal, and then you start to decompensate and things get, like scarier, like the pulse ox drops and, your ventilator alarms, or your back valve mask gets a lot of resistance, and you get drops in blood pressure or increased tachycardia. It looks like, shock is getting progressively worse. Under positive pressure ventilation, I would remove all chest seals, because your chest is going to, once the pressure in your chest is higher, than the atmospheric pressure, it's going to leave the chest through that wound tract anyway. And you're on positive pressure, so it's not like you're going to suck air back in through those wound tracts. So I would remove chest seals at that point, and either needle decompress or finger thoracotomy.
So what I'm gathering, and what honestly I've been starting to think, is maybe we're being way too aggressive because we train this way, putting chest seals on so that we can move on to the next step, whatever that may be, when maybe we should just, like, I don't know, assess the patient, and then determine if this intervention is going to do more good than bad, essentially.
Yeah. I think so. I think that's kind of puts it, in a good perspective. Like don't rush to failure on these things. And it takes time. And I think that's one of the reasons, even so, kind of like I'm working on the MT-CCC change paper for chest trauma, and that's one of the big things we're looking at right now. It's kind of separating out breathing and ventilated patients because they kind of require different care, and with chest seals or all the other chest interventions. So it's just kind of a different perspective to look at it from.
Yep.
So.
Yep.
Yeah.
Now, normally, in March, maybe you're putting a chest seal on. Potentially, you might be doing some kind of decompression, and then you go to C, getting IV access, and start resuscitating if the patient needs that. One thing I've heard and seems to be gaining momentum is, instead of decompressing a patient in shock who has some kind of chest trauma, what we need to be doing is getting IV or IO access, starting blood, and once that's actually rolling well, then start addressing the chest injury. Do you think there's any validity to that? Because it's out of sequence, of course, and there must be wrong.
Yeah, the sequence. We've been talking. I think just the community of tactical medicine in general has been talking a lot about should you do chest, respiration type stuff in March before circulation, because so with administering blood, the biggest thing, or the most important thing, is to get blood started prior to 30 minutes, of wounding, or post wounding. That's like the biggest thing that has the most mortality benefit or reduces death the most effectively. And there's even studies that show blood isn't as effective or doesn't really have a large mortality benefit if you start it after 30 minutes after wounding. So it's very important to get all that stuff on as quick as possible. And, there's varying levels of medics in the DoD. Some are faster, some are slower, and they have different skill levels. So I think, and based on how quickly tension pneumothorax occurs from the data that's available, you could honestly probably wait to treat a tension pneumothorax and give blood before, if there's indications for blood transfusion. I think sometimes this stuff is done, synonymously or simultaneously. If you have squared away team guy or RFR or some sort of first responder doing it while you're doing something else, you can obviously do these things simultaneously. But if you're strictly by yourself and you're a little bit slower and it's a long extrication, you got to run to the casualty, you got to drag the casualty, you got to get behind cover, you got to do all these things, add time to the wounding. I think starting blood maybe before and certain situations is the right thing to do. And I know we do sequence-based medicine, but I don't know if that's a training and evaluation thing or a doctrinal thing, or is it just a medicine thing? But I think sometimes you probably should start blood before in chest trauma before treating or decompressing the chest, because I think a lot of the indications for tension pneumothorax, like tachypnea, respiratory distress, low SpO2, stuff like that. It's also a sign like hemorrhage. And so, I mean, it's difficult. I mean, especially for, a guy who just ran, 500 meters, he's ripping body armor off a guy, probably just fired his weapon. His ears are ringing from, explosion, combat, whatever the tactical situation was. I mean, I think you could do it, and I think it could be right, and you're more likely to die of hemorrhage than tension pneumothorax anyway. So I mean, if you're playing the odds, just statistically, giving blood before a needle or a finger for a simple thoracostomy, statistically, you're going to be right giving blood first than really anything else. So
yeah, I think that the speed when we train chest trauma, the speed of tension pneumothorax is ridiculous. Like they would have to have some kind of tracheal destruction where they're just blowing air, through a 1.5-inch pipe into their chest in order to build a tension that fast. So I think we probably could calm down just a little bit. So make it one more realistic, and just so we can train in a more realistic way. I mean, we try to emulate that in every other aspect of our training. Why do we pile on all these surgical interventions that are far down the line, or potentially a lot later anyway?
Yeah. Because what a lot of people, I think, will say, are kind of like, because you always got to think of like the counter argument to it, or devil's advocate.
Sure.
Is, well, nobody's ever died of a tension pneumothorax doing it, the way it's sequenced right now through March. But like, I don't even know if it's possible to figure it out, but it's like, well, how many people are dying of hemorrhage because you have a medic trying to put occlusive dressings on that aren't going to stick, and they're all dusty, and and they don't even need to apply them, and then they do a bunch of needle decompressions, or technically they only do 2, but let's say they do a couple more, and because they're nervous,
put it on the wrong side,
put it on the wrong side or something, and they're messing around for 10 minutes. I mean, you can kind of get into those, those holes sometimes, I think, or some of that, tunnel vision on something, especially when you're stressed. And then, it took you 10, 15 minutes to get there, and then, you're not getting blood on in the time where it matters. So, I mean, I think that's definitely a viable option. You just gotta prove it, I think.
Right.
I'm not sure. I'm not sure you can, or I know I'm not there yet personally, but I really like that idea. So
I would think maybe instead of looking like, well, who died, how many people received chest tubes that were not indicated? I bet you there's a number. I bet you there's a number on there. And if guys are spending time on things that are not even indicated, that's just more time that you're not using getting access of some sort and starting blood.
Yeah. That's 100% true. Yeah.
Guys forget sometimes the patient lives despite what you've done. So
Yeah, that's true. Thank goodness. Sometimes, yeah. So
yeah. So definitely getting resuscitation going. I think, especially just chatting with you, definitely a smart thing. We knew that 30 minute time window. I've definitely heard it from, you have 30 minutes from the point of injury or the time of injury. I've also heard it as you have 30 minutes from the time you recognize they need it, which obviously, if you don't pay attention, like they don't need it, I guess.
Yeah.
But no, I believe it's from the time of actual injury.
Yeah, I always count it from the time you start bleeding. So
Yeah, I
whenever
think
that happens. Yeah.
that's wise. I think that's wise. Going forward, okay, we talked about needle decompression as part of that R before you move into H. There's some definitely, I think, valid arguments that those two things should probably be switched. But in that R portion of the algorithm, needle decompressions, we already talked about, you're supposed to do 2. If it doesn't relieve it, you're supposed to move on. What about finger thoracotomy? So, shoving a 3.5-inch needle into somebody's chest is not a benign thing, versus cutting a 2-inch incision and shoving your finger into that space, also not a benign thing. But the finger thoracotomy can relieve air or blood.
Yeah.
Do you think, I guess, I don't know, what's your opinion? What would be should finger thoracotomies, I guess, be done maybe faster, or that trigger to do them faster?
Yeah. So I think finger thoracotomy or costomy, that should be a more widespread skill. So like in our current tactical combat casualty care guidelines, only tier 4 medics, that's like soft medics with like deltas, mosquito and stuff like that. They're really the only people where that's like a skill for. I think you could translate or train tier 3, so conventional medics. I mean, like your 68 whiskeys, 4 Novembers, hospital corpsmen, stuff like that. I think they could do it, and I think you should. And so I think for needle decompression, really the anterior approach, I mean, it works, just not all the time. It's very varying. I think you can get a much more consistent result with a lateral approach to the finger, to the needle. So the lateral approach at the 5th intercostal space. And then I think you should just do it once. And if it doesn't work, you've already started your whole blood resuscitation or whatever resuscitation fluids available, and you're still not getting better. I would do a definitive decompression of the chest with a simple finger thoracostomy. Because that way, like there's feedback. You definitely know you're in, because you've cut down. Your finger went inside the chest. You can feel inside the ribs. You can feel hopefully lung. So you decompressed, and you're right. You can decompress fluid as well, so you can evacuate fluid at the same time. So, and in kind of our setting, it's almost always like a pneumo-hemo type scenario. Very rarely is it just like air, because of just the mechanisms. So, I think Yeah, I think it should be used more. Yeah.
Yep. Just personal experience, I've yet to damage organs with my finger. But I have definitely seen quite a few organs damaged with that 14 gauge or even 10 gauge hard needle going through.
Yeah. So like a needle decompression is not benign either. There's case reports of it hitting the heart, causing pneumopericardium, introducing air around the heart, hit pulmonary arteries, hit the thoracic artery. It's definitely not benign. There's also, there could be complications too with a finger thoracostomy. But honestly, like if you stay in kind of your landmark zones, which is like the triangular zone on the side of the chest at the fifth intercostal space, you go over the rib. You're not going to hit that, you're not going to have that many complications from just a finger. So, yeah.
Yeah. Now just going into like the procedure, I guess, of a finger thoracotomy, essentially it's the chest tube procedure without the tube. But where I see things going wrong is guys, I guess when they get to the moment of actually cutting, they now imagine themselves being like cosmetic surgeons. And so they make the tiniest incision that they possibly can. And they try to shove their little finger through there. And they have enough strength that they get it through. But now you have a seal and you've shoved your little finger in there. Nothing's evacuating. Since I'm confident that you've done these procedures before, do you have any tips or tricks on how to do this better?
Yeah. So, once you identify your landmarks, you want to make your incision kind of follow along the ribs. So it would be like posterior apical. So it should kind of be like slanted, it should be like kind of going up towards the armpit almost. So you don't want to be like straight perpendicular with your incision. It should be like posterior apical. And then basically you want to do 1 to 2 centimeters, and it kind of varies based on the person. So you want to do 1 to 2 centimeters, and you can cut through skin, and then you can cut through fat if you want to with your scalpel, and then you blunt dissect down to like your muscular layer, and then I blunt dissect a couple times, and I try to make my blunt dissection as wide as my incision.
Okay.
And then when I punch through the chest, you guys use like 9-inch pins, like large kind of curved, pliers. I put my fingertip kind of on the edge of the pin. So, I'll stop so I don't go all the way through the chest. And when I punch through, and I'll blunt dissect open. So you'll punch through, and then that's when like a lot of blood usually comes out for me. Like I'll punch through immediately. It's like blood starts coming out, and you'll get air and stuff like that. But yeah, most often it's like blood's coming everywhere. You're like, yep, I'm in the chest. And then that's when but I don't pull out then. I kind of crank open the pins again. And then I see if I can fit my finger kind of in there, finger and tube in there. And it's kind of subjective, but, so you want to wire to fit your finger and the tube in kind of at the same time, because that's how I do a 1-foot-1 swap. But we're talking about a finger, so there is no tube. So you kind of make it a little bit wider than your finger, your index finger. And then blood should be coming out, blood or air. But yeah, that's kind of how I do that part of the procedure.
Nice. So ultimately, what you want is a hole that stands on its own that's wider than your finger.
Yeah. So about wider than your finger. Mm-hmm.
Okay.
And perfect. You really when you punch through, just like because you'll go in and then you just want to rip out. It'll be intercostal muscle. So yeah, it'll be muscle. So you just dissect it out, and yeah, that usually works.
I've also seen, when you're talking about opening up your peens, definitely keep control when you're punching through so you don't go into the lung. But when we open, that changing of the angle of those peens, it comes into the chest. So do you pull traction back towards you as you're opening it?
Yeah, good point. Yeah, like don't let your instrument go deeper than like the current depth you're at when you punch through. So yeah, I would pull back and out. So
okay.
Make sure your instrument, doesn't go deeper, kind of like you said, because you don't want to damage the lung. So.
Yep. I've seen them go in just like a fork right into the lung.
Yeah.
But luckily, you opened up the side of the chest, so that mistake nobody will ever know.
Yeah.
Another technique I've seen, once they get their hole, they've at least started evacuating. To try and get that little bit left out of the chest, they'll hook their finger in the hole, and then they'll tilt the patient over and try to dump them out. Like, is this valuable, or are we just wasting more time?
That is, I mean, if you want to evacuate additional blood out of the chest, I think you need a tube in there. Like, I would just put a tube or a drain in the chest to do that. It just doesn't seem very, very reasonable. Even if you do get a little, like, let's say you do hook the chest, which is difficult, and you have somebody turn them on their side and you shake the blood out. Once you put them back down, they're just going to bleed. Blood's just going to go in their chest again. So I think if you want to fix something like that, that's the indication for the tube. Because the way I look at it, like, you do a finger thoracotomy to relieve air, like you're decompressing air out of the chest and some blood. But if you really want to, drain a traumatic hemothorax, which we don't really talk about in TCCC or a lot of pre-hospital stuff, if you want to actually drain a traumatic hemothorax, you need a chest tube placed. So that's what I would do for that.
Okay. All right. Smart. Now, speaking of, the chest is just going to continue to bleed until, we've reversed the lethal triad. We've actually built up some clots, etc. Because you're not shoving gauze in there to stop it.
Yeah.
So, it's a non-compressible bleed that we're just like hoping and praying that somehow the body just makes a clot. I've heard a couple, ways of thinking. One, don't worry about it. The body's going to bleed, then it'll clot, then that will stop the bleeding. Or I've also heard definitely remove all the blood, reinflate the lung with a chest tube attached to a pleurovac of some kind, reinflate the lung, and the lung will tampen out the bleeding. Those are two opposite ends of the spectrum from people who should know the right thing to do. What is the right thing to do?
That's a good point. There's a lot of nuance with, when you start talking about chest trauma, chest tubes, pleurovacs, water seal, negative suction, even when to remove it. There's a lot of nuance, between them. Like, I'm a PA, but there's nuance in surgeons, so that, and that's important. And, I don't think one way is right or wrong, but if I'm your PA and you're my medic, and and you're treating, and you want to treat a hemothorax, you should put a chest tube in.
Okay.
Whether it reinflates the lung, and reinflating the lung, I think there's benefit to that, but there's also benefit to letting blood clot off, so I can see that too. But I just know, well, I'll just know from, just my experience in the trauma service at Cooper, we put chest tubes in all the time, and you have retained hemothorax all the time. So, I mean, just because you have a tube in doesn't mean you're going to evacuate all the blood anyway, so you can get retained and clot. The chest, or the lung, will partially re-expand around the clot. So, I mean, it's just I think it's very nuanced and subjective. So I would, to just make it easy, if you want to, if you want to treat a hemothorax, get a chest tube. So.
Okay. Perfect. Yeah. I mean, at the minimum, that it's not going to create a tension because it's just going to push out. So it won't kill him.
Yeah.
Well, I guess what would push you towards the idea of we need to reinflate the lung?
Well, you want the lung to reinflate so you can, oxygenate the body. That's why I would want to reinflate the lung personally. But like in our environment, or in the medic environment on target, there's just no way to know if the lungs collapsed or not. Some people could do like an EFAST, and you could try to do lung slide.
Mm-hmm.
You could try to do multiple views of that. Because sometimes you'll have lung slide in one spot and no lung slide in another spot on the chest. So even that can kind of be, I think, confusing. But yeah, so I mean, I would want to reinflate the lung just so that they can breathe with it, so they can breathe better. I would still go, I think, chest tube, try to reinflate the lung, get them to ventilate.
Okay. Would you say a safe measurement that I can actually measure? I have a SpO2 monitor, just a little Nonin SpO2. I've resuscitated with blood, so blood pressure is not the problem.
Mm-hmm.
He's not oxygenating as well. I have no oxygen to give him, so he's on room air, atmospheric air. That might be an option to help improve SpO2 is, all right, let's pull some suction on this chest, see if we can at least help reinflate the lung.
Yeah, so generally with chest tubes, so the way I look at like a chest tube suction is, so basically you insert a chest tube for a hemo, pneumo, tension, some sort of traumatic pneumothorax. And you hook it up to a Pleurovac that's on water seal, and then you look for an air leak, and you put the chest tube on usually like -20 of suction, like wall suction, which doesn't exist where you're at, but and then you just do negative suction until you no longer have an air leak, and then you just transition it to water seal at that point, and then that still allows blood or effusion, whatever it is, to drain out of the chest just naturally. So yeah, I think if you have an air leak, I don't know how you could determine that. I guess with the SpO2, you're draining blood, it's still not getting better. You've volume resuscitated them. Yeah, you could try negative suction. I would try to control the suction just so you don't damage the lung as best you can. But some negative suction could could potentially help, especially if there is an air leak. Negative suction would be beneficial. Yeah, I just don't know. It'd just be difficult, I think, to determine air leak. I guess you could assume it because of the injuries. Or probably doesn't. Casualties probably do have air leaks. So, but I think you could try suction, negative suction.
Yeah. Obviously, I'm not talking about connecting a shop vac to this guy's chest. It's going to be some kind of controlled suction. Ideally through a pleurovac. And on the, I don't know if hospital pleurovacs are any different, but there's a little dial you can adjust to whatever pressure you want, and that essentially you don't need to control the suction at the wall or on the machine. You need to control the suction at the atrium, and if you're getting the effects you want, you're actually pulling air. Okay, you can leave it. If for some reason the damage to the lung itself is the atrium is not able to keep up, you could potentially increase the pressure to help pull that air out faster to compensate for that damage. But generally, at least in my experience, we've always kind of left it at negative 20, and the lung, at least potentially, it starts to reinflate, and you can notice that change on your SpO2 monitors, assuming that he's resuscitated. That's not the problem. I
think that's a good. That's a great line of thinking, especially if you've resuscitated the patient and you're still having hypoxia, you got a chest tube on. Definitely trying some negative suction. I think it'd be beneficial because you probably still have air in the chest that's causing some type of obstructive shock. So, and if there's still blood in there, it's still bleeding, it's still draining out. There's a couple studies out there that in the setting of hemothorax, tension is more likely to happen, and it actually requires less air to create it. So I think in your environment, or that medic environment, with bleeding and air and all this stuff going on, I think it's easy to kind of build up house hypoxia. Kind of down the algorithm tree, negative suction would be beneficial. So especially if you can monitor with SpO2, right? If you trend that, maybe pulse, like hemodynamics, just vital signs.
Just assess like we should always be doing. Right?
Exactly.
Maybe even more than once.
Hopefully more than one. Hopefully like 5 to 10 minutes. Yeah. That's hard. Easier said than done, though, I think. So
that's absolutely true. Absolutely true.
Yeah.
So you mentioned that you are reworking the COTC, or you're working with the COTC to revamp kind of the chest management algorithm. Do you have any hot takes on how it's going to be adjusted?
Yeah. So there's a couple things. One is, I think probably one of the biggest impacts is, I think we're gonna try to remove the anterior approach, so the second intercostal space, mid-clavicular line approach to decompression. Because just looking at, and the data out there, we don't talk about all of it. The just success rate of it ranges from 18% to 86%, which really doesn't mean anything. It's just so wide. And so I don't think it's fair. So, because, we got to think of like the E3 medic just graduating AIT, deploying wherever, let's go, doesn't matter. That guy, when he does it, or gal, they won't know if it actually works or not.
Yep.
So I think that's something we're relooking pretty hard at right now. And then another thing is, you know, depending on your age in the military, you know, this 14 gauge angiocath now is kind of it's 3.25 inch. That, you know, that's kind of the standard. You know, comes in the ARS kit, a nice little package. But before that, we used 10 gauges pretty regularly. So we're looking at that. We're trying to see if needle length and needle gauge mattered. And right now the consensus is bigger is better. So we may be kind of going backwards. We're still working out some of the details, but it looks like 10 gauge will probably be recommended over 14.
Yeah, makes sense. That makes sense.
And then, yeah, our like occlusive dressing stuff, kind of like what we already talked about. We're trying to get like maybe like hard indications for it, like clearly defining a sucking chest wound. Because like you said, I mean, we can sit here all day on the podcast and be like, oh, you shouldn't put the dressing on that wound. And, you know, and the guy's like, you know, who are these people running around doing all this stuff? And, you know, it doesn't work. I can't do that. So we're trying to find something, you know, feasible that a guy can actually use. So,
yeah.
And then,
I think that the chest seal thing, where I think the hang up is, if you can call it a hang up with March, is trying to address essentially any of the chest injuries before blood. Because especially when you're giving initial training to somebody, they need like some kind of help to remember what to do, so they're not just presented with an entire trauma patient all at once, and then you know the wheels start falling off. So here's an algorithm to make things go better, but from our latest data, it's a little bit out of order. Like, yes, massive hemorrhage kills people a lot faster than airway. Well, if they've been bleeding, we probably need to start giving them blood before we start addressing I want to say it's definitely the number 3 at like 2% or less than 2% of the casualties.
Yeah, it's like 1.1%, I think.
Yeah.
I think it's like what? It's low, like you're saying. Yeah.
Maybe we should be starting to address that before starting to work the chest. And I think if we could do something like that, maybe that would facilitate training a little bit better, and addressing things kind of in their priorities, like the March algorithm was meant to. Just my thought.
Yeah. Yeah, no, that's a great point. Because like a lot of these guidelines and stuff they are for kind of like that initial entry guy, kind of or gal, like you're saying, and trying to organize all this chaos and 8-bag explosions and all that. So, I think, we're definitely going to look at that hard. And see what kind of sense we could make of that. Because, you're right. The data is out there. You're more likely to die of hemorrhage than you are anything. So we should probably treat that way, or systematically approach a combat catheter that way.
Yep.
Kind of like ABC, like we learned ABCs for the longest time just because of ATLS, and then somebody was like, hey, like everybody, is bleeding to death because we're not applying tourniquets. And when we just switched it, I don't know why we can't just, switch it again. So,
we absolutely, we can. We can do whatever we want, right?
Yeah.
I think we just have to make it make sense, right? So like long before we started the podcast, I think, change R in March to resuscitation, C to chest. No big deal. You don't have to give me any credit whatsoever for thinking that. But
it's definitely going in a footnote. We got a footnote. Yeah.
No big deal. No big deal. There's a surgeon out there like, I thought of that first, right?
I know. Probably somebody out there is hating us right now. Yeah.
but I think, we kind of get into our own ruts. Like, it's a March algorithm. There was a time before the March algorithm was like, no, it's A, B, C, D, E, F. You just got to make that leap. Like, no, this is working, or it's not really working. We need to change it based on what actually helps.
Yeah, it makes sense. Makes sense to me.
Man, you are a great guest. I got to say, you agree with just about everything I say.
Almost. So it's pretty good. Well, I mean, I feel like people have just talked about this stuff for like forever, and it's kind of always been a thing in operational medicine. We preach all these algorithmic approaches, and then you kind of get out there and, it's just guys are just making it happen. And then it just doesn't get like codified in anything. And we're always left with, why are we even teaching it this way? It's not what we do. And so we just got to, I think, catch up to policy and, CPGs and all that stuff. We just got to catch it up to guys. It just takes time, but I think a lot of people are on the same track. So
I think so, and I think guys have probably been doing that already. We just got, like you said, we have to codify it, because those guys who are doing it already, they're getting out. They're going on to do bigger and better things. And like you mentioned, that 19-year-old kid that's going through AIT, is not really learning those lessons that were hard learned.
Yeah, absolutely. Yeah, we don't want to lose the experience we have, because it's just very rich.
Yeah, cool. When it comes to chest trauma, hemothorax, pneumothorax, tension, a mix of all of the things. Is there anything else that we haven't covered that you think are really important?
Oh, yeah. I mean, no, it's just the only thing is like an open pneumothorax, just the only, like, I guess, emergent chest trauma is a tension pneumothorax. It's not like a pneumothorax. It's not a hemothorax, at least not initially. And it's not, but like when we take a occlusive dressing and put it on a wound on the chest and create a tension, and then cut another wound in the chest to relieve the tension, I just want to like stay away from stuff like that, because it's just never made sense to me. And I just think that's just one of the things I'm trying to figure out. It's just like we seal up the chest and then we just cut another hole in it, and we think that's medicine. So
it's a surgical hole. So
surgical hole.
Better.
Yeah, it's a surgical hole. So we're just trying. So me and the working group, we're just trying to figure out some of those things, and hopefully we can follow up again. And once we figure it all out, and give you the full rundown, that'd be amazing. Perfect.
Maybe we can have you on again when you finally get these things written down.
Yeah, that'd be great.
Perfect. Well, thank you, John. I really appreciate you coming on.
Yeah, thank you, Dennis.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.